Thank you very much, Dr. Musa and Dr. Abdullah, for the invitation, dear panelists and dear colleagues. This is a patient, 60-year-old man who did not see a physician for a long time. And prior to presentation, he did have some chest pain, but did not seek any medical advice. He presented to the emergency room after having several hours of chest pain, as I said, 1 week later after having this episode. In the ER, we found the ECG normal sinus rhythm and this ST elevation in the inferior lead, so we activated the acute STEMI team, and he was loaded with aspirin and ticagrelor and did coronary angiogram. This is his left system. You see there is a moderate lesion in the proximal and mid-LAD, and also in the circumflex there is moderate lesion, and the ostium of this OM also there is some lesion. His left main doesn't show any significant disease, and this is his RCA showing total occlusion with TIMI zero flow. So we tried to cross this occlusion in the RCA with the regular BNW, but we could not cross. So we switched to pilot 50. And with that, we did simple ballooning, compliant balloon, and we noticed after that there is thrombus, and we stented that with 3/23 DES. And after the stent, we did notice that there is some spasm in the distal RCA. We gave intracoronary nitroglycerin, and we got a reasonable result. We did notice that there is sluggish flow in the obtuse marginal, so we put the consideration that the patient may develop RV infarct, and he remained normotensive, and we advised close follow-up in the ICU. So he continued to have chest pain. Just to mention, at that time we checked his troponin, and troponin is normal. That's reflect that he did have chest pain probably a week ago, and his troponin normalized. He continued to have a persistent ST elevation in the inferior lead and some chest pain. We gave him fluids, thinking that this is RV infarct. We added vasopressor, but he became tachycardic and dyspneic, and we did echo, and you see the echo that there is this is a tamponade and collapse of the RV. So at that time, we took him quickly to the cath lab, and we put subxiphoid access and got fluid, more than half a liter of blood. Now let's review the this is the last picture of the angiogram, and you see this area. This area is suggesting perforation or just myocardial blush. So now. So the image before that. This is the image. This is the image.
No, for initial PCI, the wire actually was in a side branch, a small side branch.
Yeah.
PDA was not in PLA. So that will increase the possibility of, distal.
Yeah. Well, that's a possibility. The wire in the side branch, and we use this pilot 50. But this is the last angiogram before. So now this is we're seeing this is a blush or perforation, and this is a fixed picture. And now this is the relook angiogram after we took him to the cath lab, and it's clear that there is in this area there is perforation. This is most likely wire mediated. So at that time we did balloon inflation, and just with the balloon inflation now we see another perforation, that this vessel is really collapsing because of the blood leakage. We are inflating the balloon in the first branch, and there is another perforation in the second branch. So I'm sure it's clear now. Okay, So we did, the first balloon inflation did not seal, so we did double balloon inflation, and with that on those two branches, and we did not seal. So now let's consider what's the plan now. Now, we did prolonged balloon inflation in both wires, like a kissing balloon, and we did not solve the problem. Okay, well, coiling, but we have two branches to
I
coil.
suggest to know from where the perforation exactly. There's too many branches. We don't know
well,
from
you
where
see,
exactly.
You see that wire, there is, where is the wire, there is a perforation on
I
this
mean
branch.
microcatheter and inject in the selective injection in the microcatheter.
No,
So
I haven't done. This is still just a wire. But you see here that there is perforation where the wire tip is.
yes, but which branch?
And this is the other perforation from this tiny branch. Here. From this tiny branch, there is perforation here.
But you have not been there, huh, by wires, huh? So, Waleed?
I did show you in the previous angiogram, this tiny vessel was collapsing because of this. I can go back, but this is double perforation in
Okay.
tiny.
Yeah, can go ahead.
So we tried inflating the balloon in both branches. Now you see there is a wire in very distal RCA, and it did not work. So let me just show the final, please. Okay, so the decision whether we can put a cover stent from the RCA to the PDA, but we are excluding significant amount of the RCA, and that may cause significant ischemia. So the plan was just to exclude this tiny vessel with a covered stent. That would put the covered stent to exclude the tiny vessel, and we put this graft master, and then we switch the. Now we have a microcatheter and the wire at this branch. This is the now this is the microcatheter.
من يحرك هذا؟
We decided to coil this branch, and we put the first coil. It was a straight coil, but small. It did went embolized distally, so we had to use another vortex coil. That's the curved coil. And at that time, it did close this vessel. Probably at this angiogram, it did not show. It may take a few minutes for the coil to close the vessel. And with that, we were able to close both perforation, and the patient hemodynamic improved, and he did well after that.
So, Dr. Waleed, thank you very much.